I'd like to introduce you to tonight's speakers. Dr. James Karras is a cardiologist with Cardiology Consultants of South Georgia here in Thomasville. Dr. Karras received his medical degree from Wayne State University in Detroit, Michigan, and completed his residency at St. Joseph Mercy Hospital in Ann Arbor, and he went on to finish his fellowship at Wayne State University. He is board certified in internal medicine and cardiovascular disease. Dr. Christopher Daniels is an interventional cardiologist with Archbold's Interventional Cardiology Consultants here in Thomasville. He received his Bachelor of Science degree from the University of Alabama at Birmingham, in Birmingham, Alabama. His medical degree from Meharry, is that how you say it? Meharry Medical College in Nashville, Tennessee. He completed his residency in internal medicine at Virginia Commonwealth University, Medical College of Virginia in Richmond, Virginia, and a fellowship in cardiology and interventional cardiology at the Louisiana State University Health Sciences Center in New Orleans, Louisiana. He is board certified in internal medicine, cardiovascular disease, nuclear cardiology, and interventional cardiology. Please help me welcome Drs. Karras and Daniels.
Hello, everybody. This is an interesting way to start because Dr. Daniels, being an interventional cardiologist, puts balloons and stents in people, and he literally just got a page that there's someone coming in with a heart attack. So he's probably going to be stepping out and taking some questions from the referring physicians, and then he'll come back. So we'll be playing this by ear, and I'm just going to go ahead and start. And I want to spend most of the time answering questions if at all possible. So I'm going to buzz through these slides pretty quickly and see if we can get to the questions as fast as possible. But this was not anticipated. So what is cardiovascular disease? This is a very common term that has described a group of diseases that cause blockage of blood flow. This can affect circulation in any of the organ systems, anything from the head to the toe, heart, brain, eyes, kidneys, and legs, anything that has a blood vessel attached to it. The heart disease death rate, as you can see from the slide, is very, very prevalent down here in the South. You look at when you combine men and women, you see the darker the color, the more prevalent. And we're just loaded with it down here in the South. When you break it down just to women alone, you see the same basic pattern. It really doesn't change much for men and women, but large amount here down the South. You see this little tiny Thomas County here has a little slightly less dark red, which means we're doing a good job here, but you can see what we're surrounded with. You look at stroke death rates. Again, this is a very similar pattern. The South is just loaded with vascular disease-related deaths. So coronary artery disease is usually a result of hardening of the arteries or a buildup of plaque, which is inside the arteries, is also known as arteriosclerosis. This can lead to angina, heart attacks, cardiomyopathies, which is a weakened heart muscle, irregular heartbeats of either the upper or lower heart chambers, or when the heart muscle begins to not pump effectively, can lead to heart failure. Stroke, or what sometimes some people will call a brain attack, is when the artery to the brain becomes blocked. And just as we have the heart model here showing a blockage with an unstable plaque rupturing and causing downstream damage to this heart muscle, the same thing happens in the brain, where a clot forms and then that region of the brain gets often irreversibly damaged. Heart failure is when the heart is unable to pump blood sufficiently to meet the demands of the body. In a normal heart, the blood circulates through the right heart chambers and off into the lungs. It comes back into the left-sided heart chambers, and then it's pumped out to the body. In a situation called a dilated cardiomyopathy, some people call this enlarged heart. That's kind of a grab bag term. It's not necessarily the same thing for everybody, but in an enlarged heart, the heart enlarges to compensate for something that has happened in order to be able to pump out the same amount of blood to the rest of the body to meet the demands that the body has on it. The signs and symptoms of a heart attack are wide and varied. It's a discomfort in the chest or other area of the body. It can radiate from the middle of the chest This picture is actually a cartoon of a man showing what we call Levine's sign. It's a very sensitive and specific sign where someone grabs their chest in a clenched fist manner, and it's a very, very accurate sign for to depict someone who's having angina or heart attack. But this can also be associated with shortness of breath, lightheadedness, and fainting. Women, for reasons unclear to us, are more likely to have atypical symptoms. That's not atypical, but atypical. Shortness of breath, nausea, vomiting, back or jaw pain. And some heart attacks are sudden and intense, but many start very slowly with mild discomfort. Now, this is for a typical heart attack. A quarter to a third of all heart attacks are silent, and when you add in something like diabetes, up to 50% are completely silent. Don't even know you have it. 50% of diabetics find out they have coronary disease at their first heart attack. Now, the statistics regarding heart attack is that the heart and blood vessel disease is our nation's #1 killer. About half of the deaths from heart and blood vessel disease are from coronary disease, which includes heart attack. And about 325,000 people a year die of heart attack before they get to the hospital. I usually tell my patients it's about a 50-50 chance. If you're going to have a heart attack, about half the time you will not make it alive to the hospital. And when I've had patients who've had multiple heart attacks and continue with the same potentially bad habits, I say, how many times do you want to keep flipping the coin and hoping that you win? Signs of a stroke are the sudden feeling of being numb or weak in the face, the arm, the leg, especially on one side of the body. Suddenly you can have trouble seeing with one eye or both. You can suddenly have a hard time talking or understanding what someone is saying. You suddenly can feel dizzy or lose your balance, or suddenly have a very bad headache with no known cause. With the statistics regarding stroke is that it's the third leading cause of death in America. It's also a major cause of severe long-term disability, with people over 55 having a greater risk of stroke, and the risk increases as you get older. Men, African Americans, and people with diabetes or heart disease are most at risk. So with cardiac disease, there are many, many types of risk factors. There are things that you can change and things you cannot. You obviously can't change your age, you can't change your gender, you can't change your ethnicity, and you can't change your family history. But things you can change: use of tobacco products, high cholesterol, high blood pressure, your blood sugar if you're diabetic, your physical activity levels. If you're obese, you can lose weight. You have a poor diet, you can change it. Living a healthy lifestyle really helps to prevent cardiovascular disease, so that when you're getting healthy and staying healthy, you can do a few things. You can don't smoke if you do. If you have high blood pressure, you have it checked regularly. You can become more physically active. You want to maintain a healthy weight, improve your eating habits, and then have regular medical checkups. Questions that you may want to ask your doctor is, what is my diagnosis? Don't be afraid to bring questions to your doctor. Write them down when you do have them so that they can answer them. I love when my patients bring pieces of paper with all their questions, because I know that I've answered their questions. You may not think of them, or you may blank when you come to the doctor. Oh, I had some question I had for you, I just can't remember what it was. And then think about what it is that's causing the problems, and then what treatment options you may have. There's usually more than one treatment or procedure that can be offered to help your particular condition. You also want to know what your long-term outlook is with and without treatment, because it may vary widely based on some other disease that you have. And then you have to ask yourself, what kind of screening tests should you have done? You need to be a very active participant in your care, because your prognosis really, really changes and improves if you have an insight into your medical condition. If you know what's going on with your body and you can actively make some changes in your life or your lifestyle, it'll make a big difference for you. I always like this. I love having extra sets of ears in the waiting room with me, with extra patients, family members, or friends. There's a very, very powerful study that shows about 50% of the time people do not remember what the doctor told them when they leave the doctor's office. So again, here it says, write down the questions, and then write down the answers too. So when you get home, other family members may ask you, what was that? How'd that doctor answer your question? What was the answer? And then also carry a list of your health care providers and the conditions that they're managing. Now we're going to go ahead and try and take some questions. Dr. Daniels is back. I don't know how long he'll be back.
Yeah, unfortunately, this is what happens. I am on call tonight, and unfortunately, I will have to step out within about 10 minutes to take care of somebody.
So thanks for
yeah,
that.
Absolutely. But, you know, yeah, I missed what Jim was talking about, but we're glad, first of all, we're glad that all of you all are here, okay? Because that's number one. Because, you know, you're showing an interest, and as you should. But our thing is we want to, I'm sorry, ma'am, I'm sorry. First of all, you're showing an interest, and that's the most important, to be honest with you. And whatever we can do to help educate, that's vital. The reason why I say things like these are so important, I'm just going to get personal with you real quick, and then we can go and we'll take your questions. And I told Alicia this actually a little while earlier today. I grew up in Biloxi, Mississippi, all right? And the person that lived behind me, I used to grow up cutting grass, you know, for a couple extra dollars or whatnot, and knew the family very, very well. Well, Friday night, I received some disturbing news named Mr. Walter Cook. Mr. Walter Cook took his grandkids to see one of the newest movies that came out, but Mr. Cook unfortunately passed that night from a massive heart attack, okay? Really didn't he might have had symptoms that he told his wife, but he really didn't get the care that he really needed, and that just happened Friday night. So I think the fact that you all are here and just the opportunity to speak to healthcare providers, that's vital. So please use that and ask questions, and just ask questions.
I have one that somebody asked ahead. Is it important to take your medication that's prescribed after you have a stent or angioplasty? So if you had a heart attack and you have a stent placed, what's the importance of continuing the medication the doctor put you on?
So I'll answer that one. So yeah, when we place a stent, so a stent is a foreign body that basically goes inside your coronary vessel, and through time, something called endothelialization, or basically covering of the stent, takes place. But that takes a little time. Okay, some of the newer stents that are coming out, some of the time it takes a little less time. But ultimately, we have the goal of at least a year. Some people choose to kind of pick and choose what medications they take or what medications they don't take, or I might can take this one today and maybe not take this one. And, you know, I know some people in here have done that without a doubt. Those medications are important. What can happen is if you do not take them, you can have what we call acute stent thrombosis, meaning a large clot can basically form inside that stent that I previously placed and cause a massive heart attack, and there is no guarantee that you're going to survive that. So it is vitally important that you take your medications, especially what we call your antiplatelets, meaning the medications after a stent, you take them regularly. If they're twice a day, if it's a twice a day regimen like something called Brilinta, which you're all seeing on television now, new commercials, you take it twice a day. If it's clopidogrel, Plavix, or Effient, you take it once a day. You take that along with your baby aspirin, 81 milligrams. But if your physician prescribes it, you take it appropriately. And also, I'm just going to say this, if someone tries to take you off of some of these medications because they have to do a procedure, whatever that procedure may be, you might want to talk to your cardiologist about it to make sure that it's appropriate that you take it, you should be taken off at that time.
I'm going to fall right into the other question that...
I want to add something to that. I had that exact scenario happen to me yesterday as a new patient came in from a different state. He had a stent placed, and it was about 2 months ago. And he showed up and said he had run out of his Brilinta after the first month was given, and it was now into the third month. And I was deathly afraid of what was going to happen from exactly what Dr. Daniels was talking about. We have fewer and fewer samples in our closets these days, but we did have a little bit of Brilinta. And I went out and got him one and got him a glass of water here and said, take this right now. It can be that quick that you can have a heart attack if you stop your dual antiplatelet therapy.
So one of the questions is, after a stent is placed, how do you know it's working?
So a lot of times, you know, in previous years, way back, you know, we might get periodic stress tests. We don't necessarily do that all the time now. What we do now is we follow your symptoms. Okay, we would love for a patient to end up participating in cardiac rehab. Cardiac rehab is an excellent opportunity for you to, you to build your exercise capacity, and it's actually held here at this facility. build your exercise capacity, but actually it's witnessed at all times. And what the nurses are able to do is they're able to communicate with us appropriately to keep your physician informed on your progress. Most times they will work, and a lot, what I love is when I place these and, all chest discomfort, all shortness of breath, all previous symptoms are totally resolved, and that's our goal, obviously. We place stents, to obviously get patients better. So we go clinically. And also it's important to, treat optimally with all the excellent medications, and you take all your medications. Those medications include what we call beta blockers, statin therapy, your antiplatelets.
Another question is, are most doctors okay with recording the visit so the patient can write notes?
It varies from doctor to doctor. I don't mind if patients or family members record either through their phone. Or sometimes I have patient members just hand me the phone and say, here, tell me what you're going to tell my daughter all this. They're going to ask me when I get home anyway. And we do that. Other doctors are not so okay with that. So I think it's wise that you ask your doctor ahead of time if they're comfortable with that. Some feel very strongly for it. Some feel very strongly against it. Personally, I feel that the more people I'm educating about the patient, the better. On the other hand, I will tell you from a medical legal reason, I don't necessarily know who's on the other end, and I don't know if they've been given permission to hear all the things that I may be telling. Some very sensitive things. For example, if I say, well, if Mr. Doe would stop using cocaine, he won't be having these heart attacks over and over. And they like, well, what do you mean cocaine? I don't use any cocaine. And so you have to be very careful on the information. If you're being completely transparent and then you disclose very private information, then that can lead to trouble too.
Next question, can you undo a blockage without an operation?
Without an operation, meaning without, okay, you don't necessarily have to have an open heart bypass surgery, but to totally undo a totally occluded vessel, meaning 100%, no, you cannot. Even 80, 90%, you cannot. Can you have some improvement in flow? Absolutely. I actually saw that today. There was a vessel that someone meaning did a coronary angiogram or looked at his coronary vessels back in 2012, which appeared way more significant than it did today. So he did not warrant a stent, but he's been doing exactly what he's supposed to do, taking all the medications, with the exception of just presenting with chest pain. So you can have some improvement in that, but you can't just have improvement without doing the right things. So you have to do the right things.
It's kind of like your sink trap. If you're pouring bacon grease down every day, you get away with it for a while, and then one day you wonder why the water won't go down. It's because you keep doing bad habits every single day. But if you stop doing it, it might last a whole lot longer before it clouds off.
Next question, what's the difference between a beta blocker and a calcium channel blocker? How do they work, and are there dangers with long-term use?
But it's actually a good question. The receptors, okay, beta receptors, or the other one affects the calcium's released in your cells, okay? So it's it affects that. So they're both what we call antihypertensives, okay? So beta blockers and calcium channel blockers. Then calcium channel blockers get broken down into two types, okay? Dihydropyridine or non-dihydropyridine, basically. And one of those is specifically for blood pressure, to treat blood pressure. The other one can treat blood pressure, but it also has a component where it can treat your heart rate, okay? And that's why you might end up getting one versus the other. One might be just for blood pressure, or you might get another one if you have experienced something called atrial fibrillation, supraventricular tachycardia. All of those are type of rhythm issues. And so that's dealing with the circuitry of your heart, the electricity of your heart. Can you just stop them? You said? What was the next question?
How long are they dangerous if you use them for very long?
Not necessarily. It actually can be dangerous if you just come abruptly off of the medications. Okay.
Especially with beta blockers.
Right.
There's a phenomenon called tachyphylaxis, where when people abruptly stop a beta blocker, the receptors that have been blocked are suddenly unblocked, and then your heart rate shoots above and beyond what ordinarily your heart rate would be, and that's usually the phone call that we get at Saturday night, because people ran out Thursday night and didn't get their drugs refilled. Patient's heart rate is 130, 140. It's all because they have abruptly stopped on their medications.
On that note, what about natural supplements? Fish oil.
That's a whole lecture in itself. In terms of, there's some natural supplements that are potentially useful. There's a whole bunch of things that may or may not be useful. And there's some that are frankly dangerous. I'll give you just an example. Vitamin E. A few years ago, there was quite a bit of interest in vitamin E as an antioxidant. And so everyone was in an antioxidant kick, trying to clean up these free radicals that were ravaging their coronaries. Well, some studies were done that showed that if you take more than 400 units a day, the benefit goes away and then you start getting cardiac risk. And it frightens me sometimes when I have patients come in and have bottles of vitamin E in it that are 1,000-unit capsules. And so they're already overdosing on this, which is also a fat-soluble vitamin, which means that it builds up in the system, as opposed to the B vitamins, B1, B2, B6, B12, and vitamin C, which are water-soluble, and you'll eliminate that in your urine very easily. So you have to be very careful. You can't just read on the jar, and if it says promotes heart health, you're best talking to your doctor about it, and don't just randomly take something if you don't know if it's going to help you or hurt you, or even more importantly, go against and possibly hurt the medications that you are taking. A good example would be vitamin K. If you're on a blood thinner called Coumadin, vitamin K is the antidote, and it will reverse your Coumadin and potentially could cause you to have a thrombosis of your valve or a heart attack or a stroke.
Speaking of that, I'd like to add, it might not be in this population, but we do see it regularly, especially for maybe some of your grandkids or even children, diet pills. So, diet pills, we're pretty much against diet pills. It's good, the old-fashioned, exercise. You want to watch Adipex or some of those other kind of medications, and people do prescribe them, but they definitely can cause heart issues.
This is 3 questions. What is congestive heart failure? What's the risk of having stents in your legs and fluid buildup? And what is AFib and what are its effects? So heart failure.
I'm sorry, that's the one.
Yeah.
Heart failure, and then how do stents in your legs cause it to get worse? And then AFib's a whole separate.
First two. I'll speak on the first two, and then I might probably have to leave. So heart failure, there's something called congestive heart failure. There's a systolic and diastolic component. So systolic, I like to think of your heart is actually active, okay? So the function of your heart. But at the same time, there's also a relaxation issue, and that's more what we call diastolic. Both can be equally harmful, to be honest with you. Probably systolic a little bit more. So as your heart function starts to go down, so normal heart function, 55%, greater than 55%, okay? As that, and that's called EF. EF, ejection fraction, LVEF, left ventricular ejection fraction. If any of you all have been diagnosed with heart failure, you should know what your EF is. You should know it personally. So next time you go to your doctor, what is my EF? And as simple as that. And, depending on your EF can determine what kind of medications you're on, or what medications we start or whatnot. As your heart starts to weaken, you can develop heart failure symptoms. And I know in the slides they had some of those symptoms. Shortness of breath, okay? When you're trying to go and if you're walking from here to that door, previously you were able to do that, and now all of a sudden you're starting to get short of breath, you're winded halfway through, that can be symptoms. If you're requiring multiple pillows at night, okay, or you wake up gasping for air. I'm not talking about comfort from a back situation. I'm talking about you cannot breathe. You feel as though you're drowning. That can be a sign of heart failure, and that something is going on with your heart. There are a number of causes of heart failure. Hypertension, meaning high blood pressure, can cause it. Ischemia, meaning blockages of your coronary vessels, can cause heart failure. There are a number of other conditions that can cause heart failure. There are a lot of medications that improve heart failure, though, but it's important that you're compliant with your medications. Okay.
Stents in the legs with fluid buildup.
It's hard to say with fluid buildup, stents in the legs. Stents in the legs can be that could mean peripheral arterial disease. Okay, if anyone that has coronary artery disease can also have peripheral arterial disease, and we treat peripheral arterial disease as well. Peripheral arterial disease basically represents blockages anywhere else besides your coronary tree. So you can have it in your carotid arteries, your upper extremities, your lower extremities, your abdomen, your pelvic area, meaning your iliacs or whatnot. And what that tells us is if you start having what we call claudication symptoms. Claudication symptoms are when you try to walk from here to that door, and maybe you start having a little cramping in your calf areas or the back of your legs or whatnot. You try to climb a flight of stairs, you start to have problems. You're walking around the grocery store, you start to have problems. That's really big for patients that have coronary artery disease. They're at risk for that. Patients that are diabetic, they're at risk for that. Smokers are at risk for that. And there are things that we can do to help correct, but it's also important that you do your part as well. Yeah.
Thank you.
What is the
Ejection fraction. Yeah, meaning heart function, squeeze, or whatnot.
Okay,
And I apologize, but unfortunately I need
You gotta go save a life.
what is AFib and its effects?
Okay, so, thanks, Chris.
Thank you.
Atrial fibrillation is when the upper heart chamber, either left or right, usually both, changes from a rhythm where it's squeezing and contracting in a normal fashion to where it's almost vibrating and like shivering. The problem with that is that the efficiency of the heart muscle can drop by as much as 20%. And also there's a little flap in the upper chamber on the left-hand side called the left atrial appendage. When you have blood flow that's not pumping strongly through that upper chamber, little clots can form, and they can form in that little appendage. If the heart's going in and out of atrial fibrillation, those clots could then be pumped out. The first thing they do is they go down to the lower chamber, which is the left ventricle, and then they're pumped out. As they're pumped out of the heart into the body, one of the first exits is the brain, which is why atrial fibrillation can lead to strokes. And that's why there's such a big interest in medications that lower stroke risk. Those medications being things like Coumadin, and then the drugs that you hear about on the nightly news every night and the TV stations with Pradaxa, Eliquis, and Xarelto. Those drugs, each one of them, lowers your risk of stroke in atrial fibrillation by about 80%.
How important is it for you to bring your medication with you for an office visit?
So that's a fantastic question. We encourage all of our patients to bring all of the medicines, including the jars that they're in, for a number of reasons. One is we know exactly what you're on, the exact dose that you're on, and we know the quantity. Sometimes we'll check the pill count. You may have the bottle and the prescription that we gave you, but maybe you've only taken half the amount you're supposed to. So we get a good idea of how compliant you are by taking your medication. Also, we also recognize that as cardiologists, we're not your only doctor. You probably have a family doctor, you may have an orthopedic surgeon, you may have a GI doctor, a pulmonologist, any number of other doctors that are managing your health care, and those drugs might change. So the last list that we have in your record from when you saw us last may not be the most up-to-date. And I'll add that even further, in that when people carry around their little list in their wallet, I can't tell you how many times I see this little folded up piece of paper that looked like it was written on about maybe 10 or 15 years ago, and it's been crossed off and it's been changed and edited, and even with all the edits and changes, still might not be accurate. And before we make changes, we want to make sure that we have the accurate medication, the amounts, the doses, how many refills you have left on them, and also to make sure that you're taking them when you're supposed to. Sometimes, I mean, I've seen so many things over the years, and some times are hard, and medications are sometimes expensive. People will cut them in half to try and make them last longer. Some medications aren't meant to be cut in half. You cut them, you take an extended release medication, you cut it in half to try and make it last longer, and that extended release medication becomes a quick release medication and can spike the drug into your system rapidly.
How long do you take Plavix after having stents placed?
Okay, so I wish Chris was here for that, because it's a perfect question for him, but I will answer that it depends on the stent. With what we call drug-eluting stents, which are what most people use these days, the minimum is 1 year. Most people try to go out 2 years. If we see that there are a lot of other blockages and that the patient is at risk for other types of conditions that Plavix would be useful, sometimes we just keep people on it lifelong. In the non-drug-eluting stents, or what we use, the first generation of stents, we call them bare metal stents right now. Sometimes we can get by with just 1 month of that. So you say, well, why not just give everyone bare metal stents? You don't have to take it for 1 month. The drug-eluting stents are better than the bare metal stents, and so the newer medication requires a longer medication treatment. If you remember earlier in the talk, Dr. Daniels mentioned about the endothelialization. When you put a stent in the body coats it off. And if you were to look down that artery with a scope, if you could, a couple years down the road, it would look just like the inside of an artery. It'd be all nice and smooth. When you first put it in, it looks like someone put a round fence inside the artery and blew it up. So you want that new layer of cells to form on that. And while that process is happening, you have to be on blood thinners to keep those areas from clotting.
If you develop blood clots, how will this affect your heart?
Okay, well, I don't know how to answer that because it depends on where the blood clots are forming. Whoever picked that question, they're brave enough to stand up.
If you have any blood clots, that develop like in your neck and in your back and they travel.
Okay, so if you develop clots in venous systems, okay, so like if you've heard of something called a DVT or a deep venous thrombosis, or clots that are in the legs that sometimes people will have, clots that are in the venous system stay in the vein, and if they break loose, they can travel up, but they'll travel to the right side of the heart. Let me see if I can show you a picture here. Okay, this actually works. So if a clot forms in the leg, it'll come up into this chamber, it'll get pumped into this chamber down here, and then it'll go out and into the lungs. And the lungs will act almost like a sponge or a filter, and it'll get caught there, creating what's called a pulmonary embolism. That is one way to have rapid death. So not everyone who has blood clots in the legs or blood clots in other locations will develop that situation, but it won't cause a heart attack unless it overwhelms the heart by being such a massive blood clot. For a heart attack to occur, it has to affect usually this chamber, the left ventricle. The only way it can get from the right side to the left side is to go through a hole in the heart that you maybe were born with or that developed later on in life through some other type of condition. If you develop a massive pulmonary embolism, though, this side of the heart can become so weak that heart failure will develop and people can have heart attacks that way. But it's not the traditional heart attack where a clot has formed in the artery supplying the heart muscle. Does that answer your question? Okay.
Please explain high blood pressure and the new changes to the numbers.
Okay. So this is a moving target for all of us. Everyone used to say, 140 over 90 is the highest you should have with normal blood pressure. Then it became 120 over 80. There's a lot of things that are going on in the world of treatment of blood pressure. I don't like to think of blood pressure as just a number or a target because there's a lot of studies that show that the lower blood pressure that you can achieve without symptoms, the better. In my heart failure patients, I like pressures of 90 or 100 or 110 systolic. Numbers that are often frightening to some people. They'll bring me lists and they say, look, my blood pressure was 90 over 60 this day. And I say, well, how are you feeling? I said, I felt fine. Well, good. That's a good thing. Typically, with hypertension being the silent killer, we worry about asymptomatic high numbers. I don't like to worry about asymptomatic low numbers unless it's causing problems to other organ systems. Now, the kidney doctors like to have a certain higher number than the cardiac doctors because they like to keep the kidneys well perfused. And usually the two organ systems play very well together. Some people can tolerate normal blood pressures, some people can't. I I have one lady who I took care of for many years who she would run blood pressures anywhere between 220 to 230 for the upper number to as low as 70 for the upper number in the course of a day. So it's very difficult because if you try and treat that upper number, then the time when she's at the lower blood pressure, it gets even lower. So the fluctuation within the course of the day is very important. Most of my patients that have high blood pressure, I like to encourage them to get a blood pressure cuff and then get a range of what their blood pressures are like at home, because I may only have that little 15 or 20 minute snapshot of their life in my office with that 1 or 2 readings that I get, and I don't get the reading of what it's like the other 2 or 3 months that they're not in my office. So I have to rely on information that I can get elsewhere. So having a blood pressure cuff at home and recording that heart rate and blood pressure can be very, very useful. In terms of the numbers, that's too hard of a question for this size of a crowd because there's too many other coexisting properties there where you'd have to aim for different numbers. Like I mentioned, the patient with kidney failure may require a different blood pressure than someone without. Patients with diabetes, we aim for lower numbers than we do the non-diabetic population. There's not a normal number that I can give you and say, this is the number that everyone should be. Just like, you hear the people say, drink 8 glasses of water a day. That's what the doctor says, drink 8 glasses of water. Everyone should drink 8 glasses of water. I have patients who, if they drink more than 3 glasses of water, they'll be on a ventilator that night. So you can't go with generalizations that apply to every single person.
What are the signs to watch in a heart patient who might have congestive heart failure?
Okay, and that gets back to what Dr. Daniels was talking about. So signs and symptoms of heart failure, shortness of breath, easy fatigability, inability to do the things that you used to be able to do so easily, like walking to the door, waking up short breath at night. As Dr. Daniels mentioned, there's something called paroxysmal nocturnal dyspnea. So it's when you have swelling maybe in your legs, that when you lay down at night, suddenly your body is no longer fighting gravity, and that volume of fluid can redistribute into the body. It can get into the lungs, and then after you've been laying down, you rapidly wake up feeling like you're drowning. And classically, the patient will feel like that, will rush to like a window, open up, or go to some cold air, or get a fan or an air conditioner to have air blow on them. Swelling of the legs can sometimes be a sign of worsening heart failure. It's not for everybody, because we do know that patients can have problems with just the veins in their legs. Just with normal aging, we can get some what we call venous insufficiency, so that the valves stop working the way they're supposed to, and blood can pool more easily in the legs. Salty food intake. If you eat more salt, the body loves to take in salt. And as it absorbs salt, the little mechanism inside your brain that says you have too much salt kicks in and says, hey, now you're thirsty, go get some water. You go drink some water, your body loves to absorb water too. So now it has already pulled in the salt that it loves, and now it wants to dilute that salt, pours in the water. And your body doesn't have an unlimited supply and size that it can carry all this extra fluid. So it goes and it can leak out into the legs, or in the cases where you have a weakened heart muscle, it can weep out into the lungs and then cause a fluid buildup around the lungs. You've heard people say, I have fluid around my heart, is where they often describe it. That's actually a completely different condition, but we as physicians know what that means. It's where they have fluid that builds up in the lungs and then causes a breathlessness that makes you feel like you're drowning.
Does Archbold still conduct a program? It used to be called Legs for Life. It was held twice a week, 3 weeks each month. It measured blood pressure in arms, legs, and checked your various arteries.
So I'm going to have Alicia answer that question, since she has now taken over as the director of cardiovascular.
We no longer do the program. What we found that we weren't reaching a new set of audience. So as long as we were seeing different patients and diagnosing different patients, it was okay. But we found out that the same few people came back day after day after day, so their diagnosis didn't change. So we thought we'd come up with some other ways, and it's still in progress. I enjoyed the Legs for Life, and we thought it was very important. We do do carotid screenings, mostly during the spring, and other times we do things. We're running a little small, what is the screening we're doing now? For coronary CT and CT for $90 that you know, calcium scoring. And so we're doing things like that. The Legs for Life, we'd like to get back to doing something similar to that, but we find even now when we're doing the carotid screenings, it seems to be the same few patients that come, but we're interested in doing something again. Got good ideas with it. All right. If you think you may be having a heart attack or stroke, what should you tell the EMTs transporting you to the hospital?
Go as fast as you can. As safely as possible.
The EMTs around here work very closely with us anyway. I mean, they get the STEMI pages. When we get the STEMI pages, they know we have somebody coming in. So I've gotten pulled over before, and they're like, oh, you have on red, run, girl, run. So they knew they had gotten us, you know, when we first started in the program. So we're all a team effort around the whole community, Grady County, Colquitt County. We all work together to do the fastest care. So if you get in an ambulance and you state that, they're going to take you here so that you can get treated the quickest possible.
And just like what happened when we started this lecture, when Chris was standing next to me and he just showed me, his phone had this little siren that went off, and he showed it to me, and I was like, oh no. Okay, so what happens is when we get what's called a STEMI alert, that's ST second elevation myocardial infarction. That means that someone is having an acute heart attack caused by a blockage in one of the blood vessels of the heart. When we get a STEMI alert, it can be called in the emergency room, it can be called by an ambulance. And what happens is a whole series of events go on behind the scenes that no one really knows about, but Dr. Daniels was already made aware so that he was not in a lecture one floor below the cath lab where he's right now, or if he was at home. If the techs that are in the cath lab were at home, they would all be alerted. Blood bank and lab is alerted. Tallahassee is alerted in case we have to urgently transfer the patient down for bypass surgery. Nursing is alerted, so we make sure we have beds available. The ICU is alerted. It's a whole system approach that goes on. It's not just one person getting beeped and running off to try and take care of it. There's a whole group of things that go into action. And you know, Alicia worked in the cath lab enough to know that when that happens, you know, everything just starts jumping and going in motion.
On that note, if you go to Tallahassee for a stent placement, do you get to come back for a bypass surgery? Do you come back and visit if you're our doctor? Do you get to stay locally after initial follow-up? Do you get to come back to y'all if you're the doctor?
Yeah, sure. So if we send you to Tallahassee for something that we don't offer here, then we don't give you up as a patient. You know, you come back to us as our patient. Tallahassee has an arrangement with us where they will take care of the problem that we can't handle, and then we resume care once you are released from there.
What can cause a slow heartbeat?
Okay, so a slow heartbeat can be caused by any number of things. The electrical system of the heart can age. You can get what's called fibrosis of the electrical system. And what will happen is the heart rate will get slower and slower. Sometimes it gets so slow that you need something called a pacemaker. There's also medications. There was a question earlier about calcium blockers and beta blockers. Both of those medications, certain ones in the classes, can lower your heart rate as well. Almost all the beta blockers, just because of the way they act, lower heart rate. Beta receptors are the receptors on the heart that control heart rate. So if you're blocking those beta receptors, you're making the heart rate go slower. With certain of the calcium channel blockers, that can happen too. Also, if you have problems with your electrolytes, if you have high potassium or low potassium, or sometimes with magnesium or calcium, that can affect the metabolism within the cells of the heart and can cause slow heartbeats. I see that a lot in patients that come into the ER that are, for example, dialysis patients that maybe skipped or missed or forgot a couple of their treatments, and they come in and potassium is sky high and they have a heart rate of 20. You don't necessarily have to rush them off for a pacemaker. Sometimes just taking the dialysis, getting that potassium back to normal, the heart rate comes back to normal. However, if someone's hemodynamically unstable, which means that their heart rate is so low that their blood pressure is low, sometimes a pacemaker needs to be placed. There are some external pacing pads that can fit over the chest that will give a small little electrical shock to the chest wall that will make the heart beat. If that doesn't work, a catheter can be placed in through the neck or through the collarbone area, and a temporary wire can be placed down into this chamber right here, and by stimulating a small little electrical impulse can make the whole heart beat. So there's a number of things that can make the heartbeat slow, anything from drugs to aging and to chemicals.
Why would someone go to cardiac rehab?
Okay, so just like why would someone go to a gym? If you have a trainer or someone who is an expert at knowing how much you can do and how much you can be pushed to do, you're probably going to get better faster than if you try and do it on your own. I'd like to see a show of hands of how many people have ever tried to exercise on their own. Okay? And how many people find that if they had someone pushing them and knew what their limits were and could maybe encourage them to go a little further faster, how much more would you be able to do? A whole lot better. So in cardiac rehab, we have nurses who are specialized in recognizing the limitations of cardiac patients, whether they be patients who just had heart attacks, patients who've had heart failure, patients who've just had bypass surgery or new heart valves, and they can monitor their heart rate, they can monitor their blood pressure, and then try to gradually and gently push them to get them better, stronger, and faster than they would if they were at home. Too often people will go home and say, well, I see the exercises that you do in cardiac rehab, I can do that at home. Or people will have their family members buy them a treadmill. Those treadmills become great sources of things you can hold clothes or boxes. Most people should not buy a treadmill. They should buy a used one because there's a whole lot of people that bought treadmills. They have about 5 or 6 days worth of use on it and they're folded up somewhere. So the purpose of cardiac rehab is to get you pushed along in a gentle fashion that will make you better than what you could do on your own.
It's got one too. These are all good questions. How common are silent heart attacks?
Okay, so silent heart attacks are what scares us the most. I think I mentioned earlier that a quarter to a third of all heart attacks are silent. And people wonder, well, how can that happen? Because, you see the people on TV in the movies, they're always grabbing their chest, like this guy here. That's what you see on TV. You see the guy grabbing his chest or the woman grabbing their chest. But it's very, very common to have silent heart attacks. Sometimes that heart attack is found when a doctor is doing an EKG in the office and they compare it to their last EKG. Well, there's been a big difference between this. They may have had an ultrasound of the heart that shows changes in the heart muscle function. They may have had a chest x-ray that shows changes in the heart size. When you add something else that affects the nervous system, like diabetes, then the risk of silent heart attacks goes up, and to the point where 50% of diabetics have silent heart attacks.
Why do doctors want your artery to be 30% clogged before inserting a stent?
So it's not 30%, it's 70%. Pardon?
The question was 80%, not 30%.
Oh, yeah.
Well, they don't want it to be 80% before inserting a stent. Usually the magic number based on flow, it's a logarithmic flow equation that has to do with what size of a reduction in diameter causes decreased flow. And 70% is the usual cutoff where flow becomes decreased to the end organ, whether it be the legs or the heart. Now, having said that, it depends on the vessel. There are some people that have 80-90% blockages that you leave alone because fixing it can make a much larger vessel close off. So you don't want to risk losing a whole arm to save a finger. Also, sometimes the blockages are in locations that can't be reached. Maybe the artery has too many turns or bends, or it has, it's in such a location that a stent can't be deployed. This would be a perfect question for Dr. Daniels because he faces this all the time. But generally, you have to prove that that artery has a problem with blood flow. And there's other ways to determine that other than just looking at it. You know, there's the, we call it the oculostenotic reflex. It's where a doctor looks at this, yeah, that looks pretty tight. I think I'll fix that. Well, that doesn't fly too much anymore these days. Mainly driven by Medicare and third-party reimbursement insurers. They want to have some proof that that artery is significant. So sometimes they'll do things like an ultrasound. They'll put a little ultrasound probe down the artery and try to take a picture to see exactly how narrow it is. Sometimes, as you can imagine, when you're looking at a heart cath, you only see it in one view. Maybe you see it in two views. You can't see it. You can't open the heart and take a look at the artery itself. And so if you can put a device, there's also something called fractional flow reserve. You can put another device down and actually measure if that artery is getting adequate blood flow or not, 70% being kind of the arbitrary cutoff, beyond which when you can be safe to go ahead with a stent. Sometimes though, it already looks like it's worse than it is, and sometimes they find out when they do these tests it's actually better than they thought it was.
As people age, the number of chronic conditions, heart failure, COPD, renal failure, etc., increase. How do you determine how best to treat them or diagnose them?
Well, it depends on which one is the worst. And that sounds kind of flippant, but you know, if you have extremely bad lung disease, if you are ventilator dependent, if your kidneys are failing, you may not be able to do much for some of the other organ systems. So it's like in the emergency room when someone comes in, they're going to look to see how sick that patient is and how sick they are compared to the other patients. A lot of people will be complaining, especially at flu season, they've had to wait a long time because their foot was hurt, or they had an ankle sprain because of all those people that were there that were sicker than them. And the same thing goes with your own body, that you have to kind of treat the worst of the conditions, and then all these things all play together. There's no one organ system that doesn't interact with the other organ systems. So a good example would be with the renal failure. If you have severe renal failure, if you're on dialysis, there are certain medications that might not be able to be given that would otherwise help conditions like heart failure or even COPD. They can kind of go against each other. One of the lung doctors and I are always famously getting in, not an argument, it's just kind of a spirited discussion, because my beta blocker medications that have been shown to make people live longer who've had heart attacks do just kind of the opposite when it comes to lungs. It can cause asthma, it can cause bronchoconstriction, and he's trying to get patients to breathe better and get more air, and I'm trying to keep the heart beating longer and live longer. So there's always that teeter-totter of trying to find out what's the worst of the two. And usually you can meet somewhere in the middle and get to a common ground. But when you have a lot of organ systems that are involved, it can be very difficult, very challenging for the doctor too, by the way, because one perfect example, again, would be someone who has congestive heart failure but very low blood pressure. So I have a lot of medication that I can give to a heart failure patient that's been proven to make people live longer. But if that medication lowers their blood pressure or lowers their heart rate to where they develop symptoms, then I can't give them that benefit. And that also becomes frustrating because you can no longer give them any of the things that are shown to prolong life.
If I'm having a heart attack, do I go to urgent care or the hospital?
Well, so it depends on where you're at the time. If you were outside the door of urgent care, I'd step inside urgent care and let them call me an ambulance. It's always so important to go to the nearest facility that you can get the quickest help. Because you might not be having a heart attack. On the other hand, I'd much rather you assume that you are and not go home and take some Tums and lay down and try and sleep it off, and then find out the next day maybe that you had a big heart attack that you could have avoided. Again, it sounds silly in some regards, but wherever you can get the quickest treatment. I was in Bainbridge today, and at our clinic out there, and I've had patients on the western side of Bainbridge say, well, if I have any chest pain, I'm going to drive over to Thomasville to see. I said, well, you realize you'll be passing 2 other emergency rooms on the way to get here. And whether or not you have confidence in those emergency rooms or not, you can still at least be checked out and then sent to the appropriate place if you need to. So you'd hate to be dying halfway between 2 emergency rooms when you could have just pulled into the closest one. We always advise go to the nearest emergency room.
Explain an ablation procedure.
Okay, so this is going to be another time for a brave person to stand up because there's lots of ablations. There's nerve ablations, there's artery ablations, there's, you're going to be more specific because that's a generic term.
Heart.
Heart ablation, okay, ablation of what?
Your heart.
Right, I know, but there's lots of ablations that can go on in the heart. Are you talking electrical ablation?
Yes.
Okay, all right. So some people are born with extra conduction tissue inside their heart. One of the most famous is something called a Kent bundle, and you can develop something called Wolff-Parkinson-White syndrome. And what that means is you have an extra little group of fibers that can conduct electricity down that. If electricity goes down both the normal pathway and the bypass pathway, it can set up a circuit where it can go round and round and go very, very fast, and even make you pass out. With an ablation, you can map that out electrically with a catheter. The catheter can find out where that extra pathway that you're not supposed to have is located, and they can zap that either with a freezing procedure or a heating procedure and burn that. That'll make that pathway go away. So that's just for that. That's what we call an SVT ablation. There's also ablations for ventricular tachycardia, which are lower chamber arrhythmias, where you have extra skip beats that are occurring. If they can map out and find where those extra skip beats are occurring, that can be zapped and go away. Probably the more popular right now, what people are hearing about are atrial fibrillation ablation and atrial flutter ablation. So I'll see if I can get another picture here. We'll just use this as a model right here. If you have atrial flutter, and that's actually a true medical term for us. People say, I got flutters. That's different than the true definition of flutter. But there's a rhythm where the upper chamber is beating multiples of the lower chamber. Sometimes 2 for every 1, 3 for every 1, 4 for every 1. And what happens is that circuitry is beating in a circle around either this chamber or this other chamber that's hidden back here, around and around and around. You can try to map out that area. Again, very sophisticated electrical equipment, find out where that's at, and burn in little breaks in the electrical activity so that it won't happen. For atrial fibrillation ablation, they go in to the veins where the blood returns in from the lungs. Usually you have 4 of them, some people have 5. They'll put a catheter in, and it's almost like a lariat. It opens up a circle, and they try to burn, either with freezing or heating, a circular scar in each of those locations, and hope that the electrical activity cannot spark into the heart to make that atrial fibrillation occur. Some people will have what's called a maze procedure. This can often happen during an open heart procedure, where they will surgically open the cavity and slice or burn or anything you do to cause a scar. Okay, and the thing is, the scar can sometimes heal. And that's where people will sometimes get frustrated because they'll have an ablation and they'll come back with the same rhythm problem. Go, oh, that doctor didn't know what he's doing because I'm back in that same rhythm. Well, if you took a kitchen knife and cut yourself and you had no scar afterwards, you'd be so proud of how well your skin heals. But when your body inside heals, you don't have a scar, then you're like, oh, that procedure failed. But in fact, your body's natural tendency is to heal. So that can happen. And then once there's enough spot for electrical activity to go by, it's going to start back up. I've had patients who've had to have multiple ablation procedures. And sometimes for more than one rhythm. I have one patient who's had atrial flutter ablation, left side and right side, and atrial ablation. So you can have all sorts of different ways that rhythms can be abnormal and can be taken care of electrically. Does that answer your question? Yes. Okay.
Is there any more questions?
Dr. Daniels explained the difference between beta and calcium blockers. Said one lowers the blood pressure, one lowers the blood pressure and the heart rate. But he didn't say which one did.
Okay, so beta blockers and calcium blockers are both blood pressure medications. They both lower blood pressure.
Right. One also lowers the heart rate instead.
They both can. There's a subclass of the calcium channel blockers that lower heart rate. The medications that you may or may not be familiar with would be something like diltiazem or Rapidil, Cardizem, Verilin. Those are calcium blockers that lower heart rate. Medications that are also calcium blockers that typically don't lower heart rate would be things like Procardia, Norvasc, and Lodipine. So there's subgroups within the calcium blockers, some that affect heart rate, some that don't. All the beta blockers affect heart rate. And all of them are in the antihypertensive class. They all work lowering blood pressure.
Do you recommend any specific supplements or diets that support heart health?
I don't have any specific one. The best one is the one that works for you. So that if you can keep your weight down, if you can stay active, and it's something that you can maintain, then that's what you need to do. Fad diets don't work unless you can make it part of your lifestyle. A starvation diet won't work because ultimately your body needs fuel. It may get you into the dress or the suit that you want to wear in a week or two, but it's not going to work long term. So it's most important that you try to do what will be sustainable for you and that's something you can make as part of your lifestyle. I'm often asked, what should I weigh? And when I give people the answer to that, I always get this shocked look. And I'm going to give you all this number so you can write it down on your paper, because this is just kind of a standard. This isn't Jim Karras' view of what you should weigh. This is just based on health insurance physicals and what they think you should weigh. Say for women, it's 100 pounds at 5 feet tall and 5 pounds an inch. You can do the math for yourself. And for men, it's 105 pounds at 5 feet tall and 6 pounds an inch. That's what you should weigh. And I always get a lot of laughs.
Now, did you repeat that?
For men, 105 pounds at 5 feet tall and 6 pounds an inch. For women, it's 100 pounds at 5 feet tall and 5 pounds an inch.
Got a question?
So the question is fish oil good for the heart? They're looking at larger trials on that right now. So far, there aren't any that are showing huge benefits. They're not showing any harm, but it does not take the place of some of the more potent ways to lower cholesterol, which is really what you want to do. You want to keep the cholesterol as low as possible, especially the bad cholesterol, which is the LDL.
Are there any more questions? Been a good group of questions. I've been